Good afternoon, everyone. Very excited to welcome you all to today's expert roundtable discussing the healthcare workforce. This is the 9th event in our quarterly expert roundtable series. Today, we're going to be digging a little bit deeper into the healthcare industry's ongoing labor challenges, especially as the workforce and its needs have shifted quite considerably in response to the impact of the coronavirus pandemic. So let me set the stage a little bit before we get into some of our fantastic speakers. As many of you, burnout's been a large contributor to healthcare job turnover rates, which have increased almost 10% over the last 2 years, as physicians, nurses, direct care workers have quit their jobs, in some cases have retired earlier than planned, or moved into shift-based roles to better control their schedules. And as a result, we're still roughly 24,000 jobs short of our March 2020 peak. Despite reduced staffing levels, total staffing costs have actually gone up, with labor expenses at hospitals up almost 37% since 2019. And in large part, that's been driven by higher contract labor costs to fill unplanned staffing needs. Meanwhile, amidst all this, care is growing more decentralized. We're increasingly reliant on direct care workers, allied health professionals, and nurses to power primary care delivery and support the shift to home-based care. And amidst this macroeconomic backdrop, we continue to deal with shortages of critical staff across all healthcare settings, perpetuating a lot of the challenges that I just mentioned. And therefore, it's hardly a surprise that over half of Americans report disruptions in their care as a result of a lot of the workforce shortages that I just mentioned in the last year. And so we're at an inflection point where we really need to reimagine the healthcare workforce and reinvent the clinician experience of care to serve the ever-evolving needs of patients. And so today, we're super fortunate to be joined by 5 senior operating executives and experienced entrepreneurs. We're going to share a little bit more about how they're addressing these challenges and reimagining the healthcare workforce. Excited today to be joined by Dr. Brian Donley. He is the CEO of Cleveland Clinic London, as well as the incoming Executive Vice President and Chief Operating Officer of New York Presbyterian Hospital. Dr. Sree Chaguturu. He's the Executive Vice President and Chief Medical Officer of CVS Health. Dr. Iman Abuzaid, who's the co-founder and Chief Executive Officer of Incredible Health. Dr. Shreya Kangovi, she's the Executive Director of the Penn Center for Community Health Workers. And Ankit Jain, he's the founder and Chief Executive Officer of Infinitus Systems. We're going to structure the hour into 2 roughly 17 or so 5-minute fireside chats with Brian and Sree, followed by a panel with Iman, Shreya, and Ankit. And so with that, I'm going to hand it off to my colleague, Michael, to kick things off with Brian. Michael?
Hey, thanks, Parth. Delighted to see my good friend, Brian Donley here. Brian, thank you for doing this. We have a limited amount of time, so I want to just jump right into it. You've had an extraordinary career. You're undoubtedly my most favorite hospital executive. You've just stood up a preeminent facility in London. So I would love to hear a little bit about your experience in London. I think you're in London today, but you're moving to New York. And so maybe just by way of introduction, just give a sense of what you've done over the last couple of years.
Yeah, sure. Thanks, Michael. And thanks for the opportunity to be here and talk a little bit about this. I'm an orthopedic surgeon, been to Cleveland Clinic for 26 years. My most recently here as the CEO of Cleveland Clinic London. We started this project 5 years ago. We bought a building behind Buckingham Palace. We tore it down to the ground, essentially. And then from scratch, about 10 of us moved over and started a healthcare system over the previous 5 years, hiring 1,200 people, selecting, ordering, arranging for delivery of 16,000 pieces of medical equipment, 180,000 hours of training, regulatory approval, signed 8 payer contracts, and hire 342 consultants, and put in 80 IT applications. Only one of those is the electronic medical record, and had to work through a big challenge, which was Brexit. And we couldn't imagine anything bigger than that. And I think then all of us around the world got hit with the pandemic. And we're proud that we opened this in March of this past year.
I remember vividly our hard hat tour of the construction site right before COVID. What has obviously the last 2 years been like trying to stand that up in the middle of the pandemic?
In many ways, I think all of us have experienced a lot of challenge through the pandemic. And I think we hear many stories, which I'm sure all of you on this webinar can share. Also, many privileges and great things that came out of that. So for us, it's been a privilege in order to have this experience over here and stand up the hospital.
And now you're moving to New York, I assume. You're relocating in the next few weeks, it sounds like. Give us a sense of what you expect to see when you get to New York Presbyterian as a COO.
It's such a wonderful system in New York, and very proud and looking very forward to joining what Steve Corwin and the entire leadership team at New York Presbyterian has done. And when you talk about challenges in the pandemic, being at the epicenter of that in New York City, it's astonishing to be able to join that wonderful team at New York Presbyterian.
And obviously there are a litany of issues. Parth opened by saying, and Parth is a New York Presbyterian alum, enumerating some of the challenges that the system is having. Share with us some of the specific impacts, like stack rank. What was the most acute issue that you had to confront, you expect you'll be confronting in New York?
Certainly, I think having a workforce strategy is really important. I think that's been important in healthcare for a long time, but I think the pandemic has really shifted the paradigm around how we look at the workforce. Some of those stats that were presented here at the beginning of the webinar, I think, show that to us. And when you look at US healthcare this past year and you see the tremendous expense increase over agency, it's a big force that we have to deal with. It's not dissimilar, though, here in the United Kingdom. It's from a workforce strategy also. It's a nationalized health service, but tremendous pressure on the National Health Service. The way we run healthcare is different in the countries, but the underlying dynamics of a workforce strategy, I think, are one of the most important aspects we need to be looking at.
Yeah, I want to get into some of the specific issues you've confronted and solutions you think were particularly effective, but I know you think deeply about culture. What was your observation about impact on culture?
Yeah, I think those who had a strong culture strengthened through the pandemic. Certainly was our experience. I think those that did not have a strong emphasis on culture or have a strong culture, I think weakened during the pandemic.
And what were some of the elements of strong culture? What would you call out was particularly effective?
Yeah, I'll tell you, I have a strong focus on culture. And I told you, Michael, my background's an orthopedic surgeon. So I don't have all the knowledge of it, but I'll tell you what we focus on. We focus on two things, and it's Aristotle's principles. And it hasn't changed in 2,400 years. And it's about meaning and purpose, and it's about opportunities to learn and grow. And so that's the fundamental aspect of what we focused on here. And it's that focus that allowed us to have the success that we've had here in London. Yeah. And I think there's lots of things we'll talk about. There's tactics we'll talk about. There's many different things. But I think we have to think about the reason why you go after these tactics. And fundamentally, it's about how to improve meaning and purpose. It's about how to improve opportunities to learn and grow. And the third aspect is autonomy. So another categorization is people want three things. They want autonomy, they want mastery, and they want meaning. And autonomy is around flexibility. Mastery is around opportunities to learn and grow, and then meaning and purpose. But I think as you look at all the things, we should always remember that's the fundamental aspect for thousands of years in human beings.
And how do you reconcile autonomy with variability in care? Like you do want adherence to certain guidelines, procedures. So how do you think about those opposing forces?
Yeah, I'm glad you asked that. Actually, around care delivery, not much autonomy. There has to be absolute guardrails that you have to stay within. And I think in any industry, not just healthcare, in any industry, as you reduce variation, quality always goes up and costs always go down. Yep. And so when I talk about autonomy, I talk about allowing workforce individual choices, maybe about hours they work. Or we might talk about benefits. There's certainly a change in the benefits pattern, some flexibility there. But you cannot veer off always striving for the top quality care.
Yep. I want to get a little more tactical. If we think about issues around compensation, what do you expect to see in New York? What are you hearing anecdotally in the market? Obviously, a lot of pressure on the cost structure, but how do you think about issues you think you'll confront over the next year or two in compensation?
I think everywhere there's a pressure on compensation. I think you need to constantly evaluate the market and always stay market relevant with your compensation. But you'll see me, Michael, hammer home the point that compensation, I see it as a gate. It's really important that you pay attention to it, but it's a gate that you have to get through. But if you really want to be effective and you want to be effective to the people you lead, you must drive home meaning and purpose, and you must provide opportunities to learn and grow. And I know that might not resonate with everyone, but I tell you, that's my experience, that the more you pay attention to those two, understanding you must be market relevant with compensation. That compensation is extremely important, but you cannot take your eye off the other.
And as you think about your workforce, obviously this is under the umbrella of the labor crisis in healthcare. The average age of the provider is getting younger. How do you think about training, other ways of engagement with a workforce that's in quite a bit of transition right now?
Yeah, I mean, we've certainly done a lot more digital, and certainly I think the younger workforce is much more comfortable with that. So adapting your training, I think you constantly have to be listening, to your customer. And is that really anything new, listening to your customer? But your customer is also now your employee or your caregiver in healthcare. I think looking at your customer is not just also your employee, I think is an important aspect to be a better listener.
And so again, there's confounding forces, a younger potentially workforce, pressure on costs. What do you think over the next 3 to 5 years, your unit costs, the inflation? How do you think about that? Is that something you can really get your arms around, or do you think that's going to be running ahead of inflation? Just what does that cost structure look like with your labor force?
Yeah, I guess it's hard for me to predict what that's going to be. If you'd have told me to predict 5 years ago where we'd be right now with cost and labor, I think it'd be hard pressed to say we would have known exactly where we are now, especially over this last year. So I think it's hard to exactly predict that. It's certainly, though, I think going to need to continue to be a focus, and in anticipation, that's going to go up.
Yeah, and the care models are changing. Obviously, you and I have talked at length about this over the years. The pandemic obviously drove a lot of innovation, sadly, for billions of people, but around virtual care models, a more distributed system. What do you anticipate the longer term impact on the workforce will be in those modalities, in non-traditional settings? How do you think about that?
Yeah, I think years ago we had more or less one care delivery model, and I think what we're seeing is the need actually to have multiple channels of care delivery as patients want to interact with the provider. So I think the success in the future will be the more you can model that out to your specific patients.
And you've deployed successfully. Again, I'm trying to be tactical for the audience. Are there specific strategies you think particularly were effective as the model was changing to prepare the workforce for a new set of paradigms and how they deliver care?
Certainly, digitalization is critical, and preparing your workforce with digital abilities is critical, because that's going to be an important part of future care delivery, is the digitalization. And so that's going to take a big shift, though, on not just the patients being comfortable with that, but shifting your workforce, especially in healthcare, to be comfortable with that and to learn those different aspects. I think the challenge is not expecting all workers to have all capabilities, but more, as much as you have a cardiology department, you have a gastroenterology department, then you have a more telehealth department.
Yeah, and that obviously will put a lot of pressure on chief operating officers of these systems who are confronting issues that they hadn't historically had to confront. Where do you think the boundary is for your responsibility around training and education? And I'm going to head towards more community-based care models. What will be New York Presbyterian's obligation or responsibilities to ensure the workforce is prepared for those types of modalities?
I think when you see the amount of technology that's coming into healthcare, that has to come into healthcare, and certainly we must have leaps in productivity, and that's only going to be able to be done with more technology being brought in to healthcare to make that leap in productivity. And so I think healthcare systems alone will not be able to do that. And so partnerships are going to be really important with companies that help develop that and then form those trusting partnerships. I think the responsibility for the patient will always rest with the provider, and I will always feel responsibility to that. But I think as we saw, if you look over the last 25 years, the next 25 years, I think you're going to see multiple partnerships coming out in order to deliver that. And we have to have the technology side developing that.
Yeah, and I think some of our other speakers shortly will touch on some of these new models that are emerging, which is why I think your comments are so helpful in setting that up. Let me switch a little bit more focused on specific healthcare tech solutions that you think either are particularly effective or actually you thought had great promise and ended up not having much of an ROI attached to it. Are there any observations or lessons learned there you might share?
I think there's a lot of tech solutions that deliver. Certainly the big topic is data. Having tech solutions that can bring data seem to bring great promise. I think we need a little more attention paid to having usable data for the providers and not just lots and lots of data. And I liken that in some ways to the fact that probably the importance of leadership, and not just around data, but the importance of leadership is to sift through all that information and then make very concise presentations. You know, it's interesting. I'll give you a quote from Churchill. Churchill, in the middle of the Battle of Britain, they're getting bombed over 50 nights out of 55 straight nights. Never allowed a presentation more than one page to him. Meanwhile, dealing with some of the toughest aspects ever, but no one could present anything more than one page. I think of that as the important technology companies take this data and take it for the practitioner and do the important work of sifting through it to get to the usable, actionable data. I think that's where the real leap is. And you ask that question about what have you seen that has all this promise but never does? It's having all this data available and throwing it at the practitioner. There's 1,000 million things coming at our providers every day. We need help sifting through that to get down to the concise one-page actionable data so that provider can make the right decisions for their patient.
And what does that product look like? Is that at point of care? You think there's opportunities there that will help the workforce navigate this transition?
I think there's opportunities at point of care. I think there's tremendous opportunities before point of care so that you can actually get to have the meaningful interactions by sifting out who should be at that moment with the physician. If I can just take 1 minute, Michael, the core of what healthcare is, and I'd ask all of your tech innovators to think about this, the core of what healthcare is the expression of empathy. That's what this is all about. So anyone who's participating in tech companies or you want to help, how do you enhance empathy? And empathy happens at that moment between one person and another at their greatest time of need. You mentioned burnout also. I also think the more we protect that time of empathy to occur between one person to a patient, equally important is the return of empathy from the patient to the provider. Yep. If we want to see burnout improve, protect that time so the provider can get that meaning and purpose out of that very small interval of time where empathy is expressed between two people.
Yeah, really well said. That very much resonates for me, Brian. Just in the last minute or two that we've been focusing very much on the caregiver, the provider. Back of house is in chaos also. And where do you think we are in automation, that kind of continuum where we get to an ideal state around automation from where we are today? Are we in the first inning? Are we in the 8th inning? Just what's the opportunity around automation of back of house?
Yeah, I'm just going to challenge you a little bit, Michael. I don't want to agree with being in chaos in back office, but I do think there's opportunities that exist. I think we're in the middle innings. There are a lot of opportunities. So when we look at where healthcare is and you look at the expenses, we have to take expenses out of healthcare over these next years. It's a critical aspect. And there's a lot of opportunities in back office to help with taking those expenses out. Yeah. Tremendous opportunities. Healthcare providers are so fragmented compared to other industries where there's several players with huge market shares. When you look at healthcare, there's a lot of providers, all with small market shares. big opportunities to help us on that back office.
Yeah, I probably should have used a different sports analogy. Are we in extra time of the first half of a World Cup match, or?
I'm staying away from any World Cup discussion
Okay.
at this point with the big game on Saturday.
Yeah, so my last question, who wins the World Cup, Brian? I know you've been pressured on so many other topics. Who's going to win the World Cup?
That's easy. That's easy at this point. For sure, England at this point. Only because I always am so sure since the U.S. has been eliminated at this point.
Yeah. Hey, great to see you, my friend. I can't wait to have you back on this side of the Atlantic, and I'm sure we'll see you over the winter. I'm going to hand this off to my partner, Dan Gebremedhin, and our good friend, Sree from CBS. Thanks, Brian.
Thank you.
Thanks, Michael, and thanks, Brian, for a really entertaining and interesting conversation. Sree, it's great to see you. We're thrilled to have you on our industry advisory board. We're thrilled to have CBS as a partner. And we've known each other for almost a decade when we were both internal medicine physicians at the Mass General Brigham. You were such a valuable advisor to me and have been probably for hundreds of other clinicians at that system. You then went on to run population health for the entire system, then moved over to CVS Caremark as chief medical officer, and now serve as chief medical officer for the entire CVS Health enterprise. Your perspective is incredibly important to our conversation today. And I might kick it off. CVS has such a unique position in the community, a vast national footprint, and the opportunity to bring care directly to the patient. And so I'd be curious, as we're thinking about new clinicians, advanced practice providers, what role are they playing as you start to drive care into the community directly to patients?
Dan, first off, thank you so much for the opportunity and for your incredibly kind words. I've learned so much from you as well and watching your career. So it's a pleasure to be here. So to answer that question, Dan, maybe I'll start a little bit with describing CVS Health and who we are, and then that can help us answer the question of who are our practitioners, how are we working with them to help improve the healthcare of America. CVS Health, you can think of as three individual business units that work separately and also together. Our retail pharmacy, CVS Pharmacy, which you all know and hopefully love, 10,000 locations across the United States with 85% of Americans within 5 miles of CVS Pharmacy. Within the CVS Pharmacy, we have 1,000 plus, about 1,100 minute clinics are providing a broad range of services. Initially started out with acute care services, Dan, but has expanded substantially. If you go on to minuteclinic.com and you take a look at the set of services, there are also chronic disease management, preventive health services. So a lot of primary care support services or complementary primary care services in addition to acute care services. So CVS Pharmacy, we also have Aetna's providing healthcare benefits to nearly 25 million individuals across the United States, across Medicare, Medicaid, and commercial and individual lines of business. And then lastly, we have CVS Caremark providing pharmacy benefit coverage for 100 million individuals, providing support to health plans and employers in that drug prescription benefit. So as you can think about that, Dan, we have a tremendous number of clinicians that are helping to provide services underneath those three areas. So if we talk about Caremark or Aetna, we have clinicians that are developing out those criteria, who are managing utilization management, prior authorization. So they're on support services for health benefits or pharmacy benefits. When we look at our retail side, we have pharmacists who are providing services, pharmacy technicians who are providing services, as well as our nurse practitioners. In addition to that, we also have a number of other businesses like Accordant or Quorum. Accordant is providing ultra high risk care management services with nurses. We have Quorum providing in-home nursing services. So Dan, as you can see, the business is complex. We have providers playing multiple different roles across the organization, but many of them that are providing direct care are not MDs. They are NPs, RNs, RPHs, or LVNs, pharmacy technicians. And it just demonstrates the incredible role that allied health professionals play in delivering healthcare across the country.
No, super helpful overview. And I think it gives us great context for this conversation. And you've really highlighted the importance of team-based care. Now enter the pandemic where, kind of patients historically now cannot go to brick and mortar sites of care. whereas there are now challenges for the workforce itself in terms of delivering care, remaining safe. How has the pandemic evolved how CVS Health approaches the role of these clinicians in their kind of day-to-day clinical responsibilities? And how, coming out of the pandemic, how do you anticipate that will continue to evolve?
Yeah, I think there's just been an incredible level of documentation about the impact that COVID has had on providers and the amount of burnout that we've seen. For frontline clinicians, they have seen the incredible burden, especially pre-vaccination, when the severity of patients who were coming into the hospital settings were severe and there was not enough resources to be able to provide that care. And what we've seen is that in those frontline positions, about 20% of healthcare workers have quit their jobs since they've started in those frontline positions. What's really interesting, Dan, if you start to look and start to break down a lot of this data around supply and demand, it's a lot more complicated than we initially think about it. If you think about these in absolute numbers, are there enough clinicians? Let's take nurses, for example. If you look at HRSA's data around nursing workforce, what we see is that the actual amount of supply versus demand is largely near equipoise, about 2 to 3% short on the RN workforce. But to your point, Dan, COVID has put an inordinate amount of pressure on healthcare delivery. And we know RNs or any allied health professional, medical professional could be working in a lot of different settings, not just in a hospital setting or an ambulatory setting. So what we see as part of this workforce shortage issue is not an absolute number, but it's where the allocation is from a site of care. And so we see shifting away from these acute care facilities to alternative sites or alternative roles. We see other areas, Dan, like nurse practitioner workforce, where there's an incredible expansion. And potentially, if you look at HRSA's workforce data, there's projected up to 815,000 nurse practitioners, about 700,000 nurse practitioners by 2030, with only a demand of about 360 or 370,000. So you see an incredible increase in nurse practitioners. Again, it's going to be the allocation of where they are and what types of roles they're playing. The pandemic has also accelerated work on team-based care, and Brian talked about that. But with team-based care, it shifts who is doing what within roles. And so we're going to continue to see that the supply-demand calculus will change as these new care models emerge. And so if I think about when I trained in primary care about 20 years ago, there was only one model of primary care that we thought about, which was one doctor to one patient, and generally a panel size of about one doctor to 2,000 patients. As we know, over the last 20 years, there's been an explosion of different care models that have come out, some that are home-based, some that are focused on Medicaid, some that are focused on Medicare, and each one of those have different compositions of that workforce, different panel sizes, different payment methodologies. And so we're going to continue to see post-COVID the continued sophistication in care models, which will change the supply-demand calculus here.
No, it's a great discussion, Sree, and really appreciate all of those points and all those kind of elements of data there. And you talk a lot about supply and demand, which certainly speaks to access to care. And I do feel like that was such a primary, continues to be a primary problem. We're solving access to care with a variety of clinicians in this team-based model, presumably with the patient in the center. And so I'd love to get your thoughts just around the patient experience. As you have more clinicians touching the patient, presumably providing more access, how do patients experience that model? And practically, how are the clinicians experiencing that model?
Dan, one of the interesting things, let me touch a little bit on trust, which is, I think, an ancillary piece to experience. But one of the interesting surveys that I saw recently was from the Gallup poll, which showed from 1970 to today, what we've seen is a 50% decline in the number of people who would say that they trust the American healthcare system to do right by them, that they understand them, that they are serving them. So it went from 80% to 30% who would say affirmatively that the US healthcare system, that they trust it. What we do also see, though, is that within that system, they trust nurses and pharmacists near the top of all of the professions. And that's really important insight in terms of how we think about how do we, in a society that has declining trust in all institutions, and most tragically within healthcare, how do we champion the role of nurses, pharmacists in rebuilding trust? When we think about the role of pharmacists, we've continued to invest significantly in pharmacists, expanding the role of pharmacists, as the role of pharmacists has been critical to our COVID-19 response with their role in providing up to 70 million vaccinations and tests across CVS Health. But we've also expanded the role of pharmacists in prescribing. So we have now pharmacists providing Paxlovid prescribing online. And so what that has allowed us to do is to get back to your point about patients, to be able to, one, allow them to see the providers that they most trust, but to see them in new ways with new services. And we believe that this kind of continued investment in expanding the role of trusted professionals will help us rebuild trust, but also meet patients where they are and the services that they want.
Yeah, no, you bring up such a set of powerful points around trust and communication, right? I think ultimately is what it comes down to. And as you described, some of these allied health professionals are extremely gifted communicators, speak to patients in language that they understand, and become a trusted form of continued kind of communication and support. So super important points. So I'm glad that you made those. Want to also talk a little bit about a new actor in the delivery of care and team-based care, and that is this increasing phenomenon around community health workers. And I believe that Aetna Better Health of Texas has done some really interesting work in developing community health worker programs. I'd love to hear a little bit more how you guys think about this new actor in the role of caring for certain populations.
Yeah, Dan, I'm excited that Sree is on the panel after this, and I've learned so much from Sree in terms of the incredible role that community health workers can play. And I'd share with you, I started out in medical school with a keen interest in HIV care delivery and had the opportunity for a number of years to work with a community health worker directly observed therapy program. And so community health workers that would meet patients in their settings that it was safe to them and help them with managing their care. With Aetna Better Health of Texas, we've invested in community health worker training program that ensures that we can provide the set of skills necessary for community health workers to get out into the community, build that trust. Again, it comes back to that trust and support the clinical workforce, the clinical home. And so we believe that community health workers are trusted members of the community, and that, as Sree will talk about, it's important for us to have a consistent way of measuring and training and connecting them back to the team. So we're really excited about the role that community health workers will play.
That's great, Sree. Maybe last set of questions around how we are just continually, and I think CVS Health has been at the forefront, to move care from traditional sites of care in brick and mortar settings, health systems, hospitals, clinics, into the community and into the home, and the role that shift will have on our workforce. And then the introduction of technology to enable that. I'd love to just think about maybe the next chapter for CVS Health and how you think about how these clinicians will be used, where they will be used, what sorts of technology solutions may look to enable those.
Yeah, Dan, if you look prior to 1950, I believe the data that I saw is about 80% physician visits were home visits. And now it's approximately about 2% of visits are home visits. But what we've seen with COVID-19 is that, as well as other macroeconomic purchasing behaviors, is that patients are demanding what we would, from a business term, call omni-channel experiences, like the ability, but basically it's, I need to see care in the way that's most convenient for me. And that could be in the home, it could be in the clinic, or it could be virtually. And I want to also know that all of those three sites of care are coordinated and talking to each other. I might not be the same clinician, but at least know who I am and make sure that as I transfer between those sites, it will be important for you to know that. So, Dan, for us to enable that vision, we have Epic. We're the largest install of Epic in the country. So we've got a common EHR platform across our organization. So if you're seeing MinuteClinic, you're seeing one of our virtual care providers, you're seen by a quorum, home infusion, they're all on the same electronic health record. We have consistent protocols to make sure that the way that we approach the care is consistent, and also a unified data model to allow us to be able to manage those patient interactions. We also have discussed publicly our intention to extend into care delivery with primary care as well as home care. We announced our intention to buy Signify Health. After that deal closes, we would have 2 million home visits by 10,000 clinicians every single year, Dan. And our intention is to be able to do those home assessments, but also identify what additional care is needed and connect people back into care, whether it's virtually or in clinic, with Minute Clinic, or with their primary care teams or specialists as needed. So we're really excited about that unified omnichannel experience.
Yeah, no, it's a powerful platform that you're building, and the hope is that you're bringing care closer to the patient to satisfy their needs. Sree, always a pleasure. Unfortunately, we do have to stop, but it's great to see you. Thank you so much for sharing your time and your insights with our group. I will now transition it over to my colleague Parth, who's joined by Iman, Shreya, and Ankit. Parth?
Awesome. Thanks, Dan. Thanks, Sree. Great discussion, and excited to continue it with Iman, Shreya, and Ankit. Thank you all for joining us here today. So as we heard from Brian and from Sree, team-based care and the critical role that allied health workers play in team-based care models, and then freeing clinicians up to focus on the empathy that is the core of the physician-patient relationship are all super important topics. And I know each of you probably has some awesome thoughts to share in terms of those topics and what you're building. So let's jump into it here. Shreya, maybe I'd love to start with you. Sree mentioned this, and it would be great to get your thoughts. Community health workers, they're an essential part of the health workforce, right? They're an entry point to the healthcare system for many patients. Can you tell us a little bit more about this workforce and how they might be able to mitigate the shortages that we've been talking about here today? And then please tell us a little bit more about Impact Health.
Sure. First of all, thank you so much for having me. This has been a really exciting discussion and roundtable so far. Community health workers are trustworthy people who come from within the communities they serve. They share life experience with the people that they're serving. This is an age-old workforce. Community health workers have been around for 300 years. In the US, 80 years, but it's a small workforce, and unfortunately, it's been an under-recognized workforce, but I think that's starting to change. Why is that starting to change? So far in the conversation, we've heard about the costs of care, we've heard about crippling workforce shortages in the clinical workforce, and really, frankly, a workforce that has an inability to scale and has a mismatch between the lever of medical care and what we know really drives health outcomes, which are the broader social determinants of health. We've heard about the push of healthcare into the community, which I would argue is probably the single biggest opportunity in healthcare right now. And we've heard about trust. So I think what workforce really embodies all of those principles, those are community health workers. Like I said, community health workers have been around for hundreds of years, but as with other workforces, it's challenging to get the workforce question right at scale. And so that's where Impact comes in. Impact is an end-to-end platform and system that enables health organizations to plan, build, and scale and manage their community health workforces all the way to enterprise scale. We've spent the last 12 years pretty much obsessed with how do you enable community health workers to do their best work, to advance health equity, to improve population health. And we've figured out some of the secret sauces, from how do you recruit these natural helpers who have characteristics like empathy and listening and non-judgment, and who, again, share that life experience with the people they serve. How do you train them? What are their workflows exactly supposed to look like? How do you supervise and evaluate them? So we have a tech-enabled managed services offering where we help organizations like many of the ones that we've just heard from today to really execute at scaling up this workforce in the most evidence-based way. We've had multiple randomized control trials demonstrate improvements across the triple aim.
Awesome. No, thanks, Shreya. That's a great tee up. And Iman, actually going over to you for a second. Similarly, nurses play such a critical role in care delivery, and as Sree flagged, patients are placing an immense amount of trust in nurses. Yet, as we're hearing today, burnouts at record high levels, it's leading to attrition. It's only exacerbating a lot of those shortages. And so from your vantage point, why has attrition increased and what are nurses looking for in their prospective employers? And please tell us a little bit more about Incredible Health too.
Sure. My name is Iman Abuzaid. I'm CEO of Incredible Health, and it's the fastest growing career marketplace for healthcare workers in the US today. The company is valued at $1.65 billion, and we work with over 600 hospitals across the country. On the topic of why is it more attrition happening and more turnover happening, a lot of that has to do with what other speakers have already referred to. Our demand for healthcare as a country continues to increase. Our population is aging. And we as a country have not done a great job with increasing the number of healthcare workers in the country, including nurses, to keep up with that demand. Of course, the pandemic didn't help. That created a lot of acute stress, burnout, and strain on the healthcare workforce, including nursing. And then the nursing workforce is an older workforce. There's 5 generations of the Americans in the US nursing workforce, but on average, the average age is 52 years old. We definitely have an impending number of retirements coming up as well. We survey a lot of when nurses are signing up on our platform, we are often we check why is it that you're leaving your job? And that's a common question we get. And we really slice and dice this data multiple times for the many employers that we work with as well. And we publish it in annual reports too. It really comes down to four key things in this order. Number one is that they're looking for career advancement. They're looking to either move into leadership, to cross-train, to get more specialized. It can be a whole range of topics there, but they are looking to advance their careers. And for whatever reason, they're not able to do that with their current employer, and that's why they're looking to change. The second most common reason that why there's attrition is that they're looking for better schedules. They're looking for more flexible schedules and more options in their schedules. The third is something to do with location. They're either relocating to a different geography or they're looking to reduce their commute time. And then finally, and the least most common reason is looking for more pay. We're finding that the hospitals and health systems that are focusing on putting together strategies and tactics that tackle those 4 reasons, particularly the top 2, career advancement and flexible schedules, are able to retain more nurses and are able to hire more as well.
Fantastic. There's some really good points in there, Mana, and I want to probe into those in a couple of questions. But before we do that, real quick, Ankit, we've talked a lot today about the experience of care, and studies are showing that nurses, other clinical staff, spending as much as half their time on documentation, communication, admin burnout in particular is a big driver of that problem. And so what role can technology play in improving the clinician experience of care? And just please tee up Infinitus for everybody.
Yeah, first of all, thanks for having me, Parth. It's always a pleasure to be part of such engaging discussions. And I think from what we heard from all the other speakers, a lot of people come into healthcare to serve patients. And what we've found, and I think we'll all agree, that so many healthcare workers are spending more than half their time doing things that aren't necessarily serving patients. They're serving the healthcare system. It's moving papers around, it's getting approvals, prior authorizations, just exchanging data. And I think the role that technology can play is to be that connective tissue that can connect different entities, different people to each other, so that people don't have to pick up the phone or send a fax or receive a fax just to exchange information. That interoperability should happen using technology. And it's with that lens that we started Infinitus just about 4 years ago to solve a very specific problem in healthcare, which is so much data exchanges hands over phone calls. And you go to any healthcare entity, from a pharmacy to a doctor's office to a health system to even the payers, and they've got tens, if not hundreds of people, and sometimes thousands of people making and receiving phone calls. And most of these phone calls are pretty routine, pretty tedious, and relatively structured. And what we've done at Infinitus is to build a machine that can make phone calls, that can receive phone calls. And these are phone calls that are mostly not patient-facing. These are business-to-business phone calls that are transactional in nature to exchange information that is predetermined, so the inputs, the outputs. Good example of this can be a benefit verification. You have a therapy, a procedure, a specific medication, and you need to know how much the payer will pay, how much the PBM will pay, or how much the patient needs to pay. That's something that a machine can automate today, rather than requiring a nurse or an administrative assistant to wait on hold for 45 minutes just to get that information.
Awesome. And I know we're going to come back to this topic to draw into some of that impact, Ankit. So save that thought for a second, and maybe we can jump into the impact of these models. And Aman, going back to you, you talked a lot about how the number one driver of nurse satisfaction is career advancement, moving into leadership. And in Incredible Health, you're seeing retention rates that are about 15% higher than traditional channels. What have you learned about what nurses value the most in regards to their culture and career? And what changes do clinical leadership teams maybe need to make in regards to maybe culture, career options that can drive higher retention amongst the nurses?
Sure. Our technology enables hospitals and health systems to use our screening technology and our matching technology to hire nurses in less than 20 days, instead of it taking the national average of 80 or 90 days. And yeah, when they're hiring from Incredible Health, the retention is usually about 15% higher. The reason that drives that retention is frankly just stronger matching, right? So ensuring that nurses are selecting permanent jobs that fit what their career aspirations are and what it is that they want to do with their career. We mentioned one path of moving into leadership, but there's also the path of cross-training to another specialty, expanding your skills in a specific specialty, a whole range of topics that they can really expand into. And so what we've determined is that the hospitals and health systems that are really focusing in on these approaches hire more and retain more. So specifically, when it comes to career advancement, they're investing heavily in career mobility plans so that are documented. So the nurse always knows where they're going in their career and how they can evolve it in the healthcare system. They're investing in leadership programs. They're investing in more specialty training programs. They're including nurses in governance committees to have them more involved. And these are all sort of tactics we're seeing. And then on the flexible scheduling piece, we're just really seeing more and more hospitals offer a whole range of other scheduling options, not just the 3 days a week, 12-hour shifts, but the ability to do 4 days a week, to do weekend shifts, to join a float pool for even more flexibility. We have teams that are creating internal travel groups too, travel nursing groups too. They're really exploring all these tactics to drive up retention too.
Yeah, and it's such an important point. And obviously, Sree talked a lot about team-based care and how we bolstered the clinical workforce. And in addition to nurses, community health workers, Sree, obviously are a super important part of that. And I'm curious if you could talk a little bit more about the community health worker experience of care. Why are community health workers coming to your platform? And what impact have you seen community health worker-led models achieve?
Yeah, there's a lot to unpack there. Great questions. Maybe I'll take them in reverse order. So there's a lot of variability in community health worker programs. Saying community health worker programs are effective is like saying movies are good. It's just an umbrella term. So the devil's in the details. When you look at the 3 randomized control trials that we've performed of the impact model across about 9,400 patient months, you'll see pretty consistently improvements in the triple aim. So $2,500 net savings per patient starting in fiscal year 1. That's a 250 to 1 ROI for the payer. Really high rates of engagement, about 70% engagement, with 91% of people completing their full 6-month program with a community health worker, improved CAHPS and HCAHPS scores, improved chronic disease and mental health. So how do you get data? How do you get outcomes like that? How do you build a community health worker program to deliver those outcomes? It really goes back to figuring out what the secret sauces are that really enable community health workers to do their best work. First of all, you have to hire the right people. Being a community health worker isn't a job, it's a calling. So we with Impact we have a recruitment engine that identifies these altruistic natural helpers who have traits like empathy and non-judgment. We have a gamified referral app where community members can actually get paid for referring us the people that they know out in the community who are doing good without being asked. So we're able to identify these wonderful people all around us and then solve for things like training and supervision and workflows. One of the most critical things in the impact model, and something that's baked into the technology, is that it really allows community health workers to get to know their patients as people. Each community health worker learns tell me your life story, and what do you think we should be doing to improve your life and your health? And then they do that, whether it's battle an eviction notice, plant an urban garden, get you into high quality primary care. That's radically different from what we do in healthcare. We typically tell patients what to do, or we use big data or checklists to guess what they may need. Impact community health workers, they ask and listen. And all of that is really enabled by the technology and this infrastructure so that you can actually, again, get those kinds of results that we're all looking for.
Yeah, and Sree, that's a perfect tee up, actually. Technology, if it's not designed correctly, it can add to burnout. It can, instead of alleviating it, it can contribute to it. And so I'm going to ask this question to all three of you, but maybe Ankit, starting with you. How should technology be designed and structured to fit within the existing workflow for a community health worker or a nurse, for example, and create real attributable value? And please just mention any anecdotes that you have encountered along the way building Infinitus that speak to product market fit and scaling that impact.
I think understanding workflows is so critical. I think it's so easy, especially for technologists who have an idea and they come with the best intentions to say, I'm going to build a whole new silo that you need to now go work inside in order to see this amazing impact. And we see this day in and day out where you go, hey, I have a new portal. And by the way, the number of companies that say, oh, Epic sucks and we don't want to integrate Epic, but we need you to come and work in this other thing. And we'll put a link in Epic, which will then open an iframe, which will go do something else. And suddenly you've got data that's completely segmented across two different systems. And I think while in isolation, it makes sense for that worker who is looking through their entire day and wants to work through their workflow, it's actually quite painful. And I think when you step back and you do the hard work of really piping in technology breakthroughs into the fabric of a worker's day, people take it and adopt it much faster than you'd expect. And I think that the key thing that we've been fortunate to be able to do is to define where those entry points and those exit points are. One of the things we try to say at Infinitus is we want to take every phone call that happens and replace it with an API call. So the moment you go to click call or pick up the phone and make a phone call, that's when you should click a button and then the machine should do the work. Wherever you are, whether it's in a patient management system, an EHR, a pharmacy management system, or in a Salesforce instance because you're a patient access financial access program, we need to be right there in the worker's workflow. And I think by doing that, we found that everyone thinks of us as a platform that is augmenting them, that is in their workflow, rather than a distraction that takes someone out of their workflow. And a separate aside, most companies that are adopting cutting edge technology have performance improvement groups, have groups that are measuring the efficiency of all their workers. And the second you have a solution that is in a silo, breaks the way they calibrate their workers day by day. So it's very hard to attribute that value back to a solution that they've taken up. But if you can be in line with their workflow, it makes that impact story much easier to tell, which is a win for a company building the technology. It's a win for the worker that says, hey, now my day is much more productive. I'm able to spend more time with patients instead of on administrative burden in our sense. And for the champion that went and put their head on the line and say, let's adopt technology that has a promise of changing our efficiency.
Super, super insightful, Ankit. And maybe in the last couple of minutes we have here, I want to touch on this topic that Brian brought up, which was around using technology to reinforce empathy between patients and their clinicians. And Iman and Sree, this is a question for the both of you, but in your experience, what role can and should technology play to enable that? Iman, maybe start with you quickly and then Sree following that.
Okay, our technology is in the back end because it relates to hiring. So we're not so much interacting with patients using our technology. I will say just a couple of things. So one is, I think it's critical for any technology solution to have an extremely strong business case. At the end of the day, you're working with leaders that are driving the bottom line. Whatever you come up with, whatever you create has to have a very clear return on investment. In our case, we save each hospital location we work with at a minimum $2 million per year minimum in temporary labor costs that they don't have to spend because they're able to hire permanent nurses faster, as one example. And then another is just, I'll just mention that whatever you're building and delivering needs to be 10x better than what's already out there, right? Better might be defined as faster, cheaper, et cetera. And then I would also just question the need for heavy integration. That isn't always necessarily required. In our case, because it's a hair on fire problem that we're tackling, we haven't been forced to build like full-blown IT integration. And in fact, we prefer the IT teams don't get involved in our deals and our ability to close our sales.
Spot on, Iman. And Sree, maybe if you have any quick thoughts, would love to hear them.
Yeah, I think that empathy is really what we should be solving for. I don't think it's limited to clinicians. I actually think that community health workers probably have the market on empathy because by definition, there are people who share that life experience to begin with. From a technologist standpoint, you have to build in empathy. You have to design for empathy. And that requires end user design. The way that we built Impact, we started out by interviewing 1,500 people who are insured by Medicaid or who are dually eligible. We talked to them on porches, shelters, bedsides. We asked them what made it hard for them to stay healthy and how they would design a solution. And that 70,000 patients later is Impact. So if you can't build without the end user and then be surprised when you have an unempathetic, clunky system, they have to be front and center throughout.
Fantastic. What a way to wrap it up. Thanks for that insight. Iman, Sree, and Ankit, thank you so much for the time here today, and super helpful to learn about what each of the three of you is building. And as we close the session out today, also want to thank all of our guests, Brian and Sree included, for their time and super insightful advice. We've covered a bunch of ground. Obviously, there's a lot more to talk about. So please reach out to us or any of our speakers here today to continue the conversation. Thanks again, everyone, for joining, and we're looking forward to seeing you for our next session.